Okay. So now we are stepping into the adverse drug reactions and various supportive cares given during chemotherapy. So you know that all the drugs tends to produce the adverse drug reaction. Okay. So chemotherapy also not under the exception. So all the chemotherapeutic drugs works by abolishing the rapidly dividing cell that you know it produces a cytotoxic effect. But what is the problem? These chemotherapeutic drugs are not selective to the cancer cell. They may also have a toxic effect on the non-malignant normal cell also. So that's why the patient experiencing a lot of toxic effects and adverse drug reactions. Okay. So now, what are the general toxicities the patient usually encounters? The first is a bone marrow suppression. So all the cancer cells are acting on the rapidly dividing cells and the resting cells or not. They will also act on the cells present on the bone marrow. So the depression of bone marrow will result in thrombocytopenia, leukemia, anemia, everything. So what will happen if all the counts tends to be low? That patient will be more prone to bleeding. If there is low platelets and also there is higher risk of developing infections. So in this case, we have to ensure the appropriate antibiotic prophylaxis is being followed or not. And also in the lymphoreticular tissue, due to the inhibition of lymphocyte function, there will be a suppression of both humoral immunity and cell-mediated immunity. So in this way also the patient is more susceptible to various kinds of infections. And regarding the oral cavity, so most common adverse drug reaction is a mucositis. Okay, so all the drugs like capecitabine, 5-fluorouracil, all these drugs will produce a mucositis, okay, ranging from inside the oral mucosal membrane to entire GIT. Okay, they may produce the mucositis. And also there will be a stomatitis, mouth sores also the patient used to have. Okay, so bone marrow suppression and immunity, more prone to infections and oral mucositis. Then we have xerostomia, which is a dry mouth also most of the patient used to experience. And regarding the gastrointestinal, there is a chances for diarrhea and constipation. Both may occur depending on the nature of the drug. And also, most of the patient will experience nausea and vomiting, which is a major topic. Chemotherapy induced nausea and vomiting. And all the chemotherapeutic drugs tends to cause the alopecia and dermatitis, and they may also cause impotence, oligospermia, and also inhibition of ovulation and amenorrhea. And I told you about the handling and compounding. No, if that personnel is pregnant or he or she is about to pregnant, they should not be encouraged to practice the chemo handling. And also for the fetus, it may abort or it may also even cause the teratogenesis and fetal death. And there is something called tumor lysis syndrome. So that we will discuss in the upcoming slides. Okay. So first, what are the common toxicities? So first, we have discussed about the mucositis. So mucositis means ulcerations, okay, over the GIT mucosa. And one more thing we have discussed is a anemia, myelosuppression, everything. And there is something called palmoplantar keratoderma. So this is a hand-foot syndrome they used to say. So which is a cutaneous toxicity associated with the drugs like 5-fluorouracil, cytarabine, etc. So what they will do, for a precaution, they will prescribe these certain emollients like Hafus cream is there, which consists of urea and lactic acid. So like that, some kind of emollients will be given to the patient. And also there is a chances for myelosuppression, malignancy, febrile neutropenia. So if febrile neutropenia occurs, we have to prescribe the antibiotic, especially in our hospital antibiotic. See, if there is a neutropenia, first line will be cephalosporin. Okay, if it's for the second line, neutropenia, or even the patient person first line drug, they will use some third generation like ceftazidime, like that. They will as per the institutional antibiotic policy. Oh. So first, so there are some drug specific toxicities. So especially cisplatin, I told you cisplatin. Okay, now am I visible and audible? Can anyone please confirm me?
Yes, sir.
Okay. So there are some drug-specific organ toxicities like bleomycin will cause pulmonary fibrosis, and doxorubicin will cause cardiotoxicity. All these vincalclats, vincristine, vilbrastine, minorelbin, and all produces severe peripheral neuropathy. and taxanes also will cause the neuropathy, like that. We'll be discussing in the upcoming slide. So first, let us discuss about the chemotherapy-induced nausea vomiting, which is a major one. So we might already have been studied in our third year pharmacotherapeutics also. So chemotherapy-induced nausea vomiting occurs when the chemotherapeutic agent trigger the chemoreceptor trigger zone. So how they will trigger, there are two central and peripheral pathways which we will discuss. So now it is always advisable to prescribe the antiemetic prophylactically. So before, usually for all the patients who are all coming for the chemotherapy, there will be a pre-medication with the antiemetic. So after the administration of antiemetics only, they will proceed for the cytotoxic administration. Okay, but in case of monoclonal antibody targeted therapy, immunotherapy, there is no need of antiemetic prophylaxis. They will not give. Okay, so only with the cytotoxic, and also there is a categorization, highly hematogenic drugs like that, which I will tell you. So depending on that, they will give the pre-medication with the antiemetic drugs. Now there are two pathways. One is a central pathway, another one is a peripheral pathway. So peripheral pathway deals with the acute phase, but central pathway will be a delayed. Okay, so peripheral pathway primarily involved in the gastrointestinal tract, where the enterochromaffin cells of the gastrointestinal tract will release serotonin. These serotonin will be bind to the serotonin 3 receptor present on the vagal afferent of the vagal nerve, so which may reach the chemoreceptor trigger zone. Sorry, yes, and it will ultimately results in the MSS. And also regarding the central, which predominantly involved in the delayed phase, primarily in the brain. There on the area chemoreceptor trigger zone, that is the area post trema, there will be a release of substance P. This substance P will get bind to the neurokinin 1 receptor, which will cause nausea and vomiting. So you can appreciate from these images. So the chemotherapy drug, chemotherapy drug. So after reaching the area post trauma, there is a release of substance P. Substance P gets binding one receptor, which leads to CANB. And regarding the peripheral pathway, there is a release of serotonin from the enterochromaffin cell. Serotonin can bind with the 5-HT3 receptor. As a result, there is a CANB. Now, how to treat? So here, either we can give a neurokinin 1 receptor antagonist, or else we can give 5-HT3 receptor antagonist. These two are the main therapeutic choices. Along with, we can give certain CNS depressants like olanzapine, dexamethasone, like that. So how about the drugs, various classes of drugs used as an antiemetic for the chemotherapy patients? So first, the neurokinin 1 receptor antagonist, we have fosaprepitant and aprepitant. Both are same drug. Fosaprepitant is an injectable. Aprepitant is available in an oral dosage form. Available in both 80 mg and 120 on day 1, followed day 2, day 3 and all, they will give 80 mg. But fosaprepitant available as 150 mg intravenous. For adult patient, they will give 150 mg on the whole. For the pediatric patient, they will calculate 4 mg per kg. Okay, per kg 4 mg they will calculate. And maximum dose for even pediatric patient is 150 mg only. And regarding the serotonin receptor antagonist, we have ondansetron, we have palanosetron, we have granisetron. But in our hospital, we are using palanosetron, which is available as 0.25 mg, 5 ml ampule. Okay, so given as a whole for the adult patient, for pediatric, it will be 0.02 mg per kg. Okay, and certain corticosteroids like dexamethasone also we will be using in the pre-medications, and other antipsychotics, especially olanzapine, we are using. Traditionally, conventionally, many protocols recommending the usage of olanzapine. There are certain guidelines for the pre-medication prophylaxis for MSS. That is, certain American Society of Clinical Oncology recommends certain guidelines, and the National Comprehensive Cancer Network recommendations. Like that, there are some standard guidelines available for the proper antiemetic prophylactic process. So there are the categorization. Okay, we can categorize the chemotherapy based on the hematogenic risk. There are some highly hematogenic chemotherapy. For these highly hematogenic chemotherapy, for example, protocol containing adriamycin and cyclophosphamide, protocol containing cisplatin or carboplatin, so actinomycin, all these, some of the highly hematogenic chemotherapy drugs. So we have full Usually, we will be giving fosaprepitant, antagonist, palacestrant, 5-HT3 antagonists, except olanzapine. Things we will be giving the patient in our institute for hematogenic chemotherapy. And also, there is a trial going on in our institute regarding finding the optimal dose of olanzapine in the prophylaxis of highly hematogenic chemotherapy, like that. So, for moderately hematogenic, some 2 to 3 drugs are sufficient. Like we can give fosaprepitant along with palnocetrone or dexa, or either we can skip the DEXA if the patient is having steroid toxicity. We can give simply fosaprepitant and palnocetrone, like that. And for low hematogenic drug, like the drugs like docetaxel, etoposide, and all, there only one drug is enough, like palnocetrone, either palnocetrone or fosaprepitant. For primary choice is 5-HT3 receptor only, because the central pathway deals with the delayed phase. Delayed means 24 hours after the chemo, which is controlled by the substance P. Acute is within 24 hours. So for that, it is better to give the serotonin receptor antagonists. And there are some minimal drugs for certain chemotherapy, especially all the monoclonal antibodies and all. We will not be giving any anti-emetic prophylaxis. There is no need. Okay. So regarding myelosuppression. So myelosuppression means they reduce the RBC, also WBC, platelet, everything will be falling down. So what if neutropenia occurred? So usually before proceeding with the chemotherapy, that is, for example, if a patient is having chemotherapy tomorrow, today they will be coming for the hemogram. So on that we will be checking the hematologic parameters. If the WBC counts considered to be low, that is the patient is unfit for the chemo tomorrow, there will be administration of stimulating factor, that is filgrastim. So filgrastim is produced by the E. coli, which is produced by the rDNA technology, in which the GCSF gene is inserted. Okay, so that is the filgrastim. Filgrastim will be administered on the day before the chemotherapy if the patient is hematologically unstable. Okay, for the chemotherapy, because we can't delay the chemotherapy. The disease may progress. So probably they may delay by 1 or 2 days, but more than that, it is not acceptable. Suppose prophylactically certain drugs no highly myelosuppressive. So in that case, what they will do after the 24 hours after the completion of chemotherapy, they will administer pegfilgrastim. Okay, that is polyethylene glycol with colony stimulating factor. That is PEG-GCSF they used to say. So it will be administered continuously. It is available in 6 mg, 0.6 ml. So which is a full dose will be given for the adult patient. For pediatrics, it is 0.1 mg per kg. So it is given prophylactically 24 hours after the chemo. Okay, in order to prevent the uh, absolute abnormal neutrophil count. Okay. So this is regarding the neutropenia. Likewise, this neutropenia, PEG-GCSF, why they are giving after the chemo, before chemo, plain GCSF means PEG-GCSF elimination is non-linear. That is, it is neutrophil mediated clearance. So as the neutrophil recovery rises, there will be a PEG-GCSF excretion. So the serum concentration of PEG-GCSF is inversely proportional to the neutrophil count. Okay, as the neutrophil count rises, the concentration will falls down. Okay, and also we should not appreciate the frequent administration of PEG GCSF, because the single injection it effects itself will last for some 16 hours to 5 days approximately. So there is no need of frequent administration. Now, in case of thrombocytopenia, they will administer romiplastine 250 micrograms, okay, which is also like a GCSF. Or if more severe, there will be a platelet transfusion. Likewise, PRC transfusion also will be carried out. Or more severe, the patient is not responding to anything, there will be a bone marrow transplantation. Okay, so when the complete stem cells are damaged or destroyed, there is a recommendation for bone marrow transplantation, which is the procedure in which a patient receives the healthy stem cells, okay, the blood forming cells, to replace their own stem cells, okay, that have been destroyed by the treatment with radiation or high doses of chemotherapy. Okay, the healthy stem cells may come from the bone marrow of the same patient or from the related or unrelated donor also. Okay, so it can be autologous. Autologo means the own stem cells will be collected and stored before the treatment, or else it can be allogenic also. So using stem cells from some unrelated or related donor, or it can also be synergenic. that is stem cells donated by the identical twins. So next is the oral mucositis. So as I already told you, there will be a inflammation and ulceration over the GIT mucosa. So for that, they will give some antifungal prophylaxis, and also they will prescribe cotrimazole mouth paint, candide, and Zytigel, which contains choline salicylate and benzalkonium chloride. So in our hospital, there is a department called pain and palliative care. Usually, oncology is a multidisciplinary team. There will be a medical oncology team, there will be a surgical oncology, there will be radio oncology, there will be psycho oncology, there will be radiographic department, clinical pharmacist there, nurses department, and pain and palliative care. It's a multidisciplinary team. So pain and palliative team, they will only deal with the treatment of the toxicities and the adverse drug reactions. So in our institute, they have found one new formulation. So they will prepare a mouthwash on their own. So usually they will add one morphine tablet, one 4 mg Dexa tablet, and 5 ml of multivitamin injection they will add, and they will add 5 ml of Benadryl syrup and 5 ml of Mucin. So all these will be added and dissolved completely. Totally, it will make up to 15 ml. So they will give 5 ml dose thrice daily. So which is they found by research study in the pain and palliative care department. So this mouthwash they will give, or some other benzalkonium like that, some kind of mouthwash they used to prefer to the patient. So mucositis is the inflammation of mucosa, the mucosal membrane that lines the mouth and the entire GIT. And regarding the pain management, which is also handled by the pain and palliative care. So why the pain is happening in the cancer patient? Because the cancer may grow into the nearby tissue, or followed by surgery, the patient may experience pain, especially in bone cancer like osteosarcoma, Ewing sarcoma, and all. The patient will not be able to walk. They will feel severe pain. Okay. So as the tumor grows, it can also put a pressure on the nerves and the bones or organs. For due to that, also the patient may experience pain, and also the tumor may release certain chemicals that can cause pain. Okay, so that pain intensity, the pain score will be assessed by the pain and palliative care team, by the Swan Baker Faces scale is there now. So by that they will assess, and if it is a mild pain, they will treat with some basic paracetamol itself. And if it is moderate, they will prescribe tramadol with paracetamol. And if it is severe pain, they will prescribe morphine, 1 mg, 2 mg, or even 5 mg, like depending on the patient's tolerability and condition. They will prescribe morphine with paracetamol. And coming to certain supportive treatment. So, for example, I told about cisplatin day before yesterday. Cisplatin is a highly nephrotoxic. There will be a hyperhydration before administering the cisplatin, I said. So, cisplatin is the coordinate metal complex with a significant anti-neoplastic activity. But the side effect, including the acute and chronic renal insufficiency, and the renal magnesium also will be wasted, so that it will lead electrolyte imbalance. Especially, it may cause hypomagnesemia, hypocalcemia. The phosphate will be reduced, potassium will be reduced. Okay, so that what we will do after completing cisplatin infusion, there will be a post hydration with the electrolyte replacement. We used to give potassium chloride and magnesium sulfate. So, and also, what is the purpose of giving intense hydration? To overcome the risk of nephrotoxicity, and giving electrolyte replacement to correct the electrolyte imbalance caused due to cisplatin. And also, we will advise the patient to drink the plenty of oral fluids for more than 5 liters per day. Next is supportive, methotrexate. So methotrexate, when we are giving, we will give a rescue called leucovorin. So usually we have discussed the mechanism of action of methotrexate. So methotrexate, what it does, it binds to the dihydrofolate reductase inhibitor. Okay, so here the methotrexate, it inhibits the dihydrofolate reductase inhibitor. It also inhibits the thymidylate synthase. Now, so methotrexate binds to reductase and prevents the cell from using the folic acid produce amino acid. So as a result, what will happen, since there is no protein, the cell will die. But the problem here is the normal cell will also die. As we already discussed, chemotherapeutic agents are not selective to the cancer cell. Now, but we have more cytotoxic effect on the cancer cell than that of the normal cell. So after giving the methotrexate, that is, it can be considered as a poison here, we are giving an antidote called leucovorin, okay, LV, which is nothing but calcium folinate. So this leucovorin only the normal cells can use. Okay, So we use a drug called leucovorin, which is usually given with 15 mg per meter square dose. Okay. So what this leucovorin does? This leucovorin will be converted to tetrahydrofolic acid by different pathway. Now, what is happening here? So since the methotrexate is inhibiting this enzyme, the formation of tetrahydrofolic acid is inhibited. So as a result, it is not available to produce the amino acid. As a result, the cell die. But since to prevent the normal cell from this effect, we are giving directly this tetrahydrofolic acid. Okay, so we are giving the rescue. So now the cell will have the tetrahydrofolic acid. It will produce the amino acid. Okay, but when we rescue the normal cell, we have to think that whether are we rescuing the cancer cells also? No, the cancer cells do not seem to be able to use the leucovorin in the way the normal cells do. Okay, the cancer cells don't seem to be use the leucovorin efficiently. So we are giving the leucovorin rescue for the normal cell to produce the protein and the cycle to go on. Okay, so that is the drug called leucovorin. So which we will be giving whenever we are administering the methotrexate, especially high dose methotrexate. Okay, it will be given in the form of 15 mg per meter square. Okay, it is a 5-formyl tetrahydrofolic acid. That is in the normal pathway, the formation of tetrahydrofolic acid is inhibited by methotrexate. But we are giving leucovorin directly in the form of tetrahydrofolic acid. So, but it cannot be used effectively by the cancer cells. So, it can be effectively used by the normal cell so that the required protein will be synthesized, so that the toxicity can be reduced. Okay. So now how about the dosing? So if there is a high dose methotrexate and all, we have to infuse for about 24 to 36 hours. So you should understand one thing: the leucovorin is antagonizes the action of methotrexate here. So we should give the high doses of methotrexate. Sorry, we should give leucovorin only after 42 hours of starting the methotrexate. Okay. Suppose we are administering now methotrexate. So from now, after 42 hours only, we should administer calcium folinate, which is the leucovorin. So next is a leucovorin with 5-fluorouracil. So for methotrexate, we are providing a folic acid rescue to the normal cells. But with leucovorin increases the cytotoxic effects of 5-fluorouracil. So it prolongs the action of 5-fluorouracil by increasing the binding. So there it provides the tetrahydrofolic acid as a rescue to the normal cell. But here the leucovorin increases the binding of 5-fluorouracil to the thymidylate synthase, so that there will be an increased cytotoxic effect. Now, so with high dose methotrexate, we have to ensure urine alkalinization. Okay, so we have to alkalize the urine with the sodium bicarbonate, and hyperhydration is usually recommended. What they will do before starting the high dose methotrexate, in a sense, it will be 3 gram per meter square to 5 gram per meter square. Usually, it will be given for acute lymphoblastic leukemia relapsed patient, not normal ALL. ALL relapsed patient. They will be giving high dose methotrexate. So before giving my high dose methotrexate, the previous day they will start hydration. What they will do, they will be adding 5 ampules of sodium bicarbonate to the 5% dextrose, 500 ml of 5% dextrose plus 5 ampules of sodium bicarbonate. So will be given at 150 ml per hour. Okay, so for 24 hours there will be a continuous hydration. So they will check like 3 liters per meter square, like that they will calculate. So on the whole, it will be administered at the rate of 100 ml per hour for 24 hours. That is the pre-hydration. And during administration also, the continuous hydration will be going on. Usually for high dose MTX, they will put up a central line. On that, there will be a 2 entry points. So one, there will be a continuous infusion of methotrexate. On the another one, there will be a continuous hydration. The same 500 ml 5% dextrose with the sodium bicarbonate. And also the patient will be prescribed with the citral cough syrup. They will be advised to take 10 ml twice daily. Depending on certain characteristics, they may adjust the volume. So why for they are doing that? To alkalize the urine, because the methotrexate tend to precipitate and tend to crystallize in the kidney, and which ultimately cause the nephrotoxicity. So for that, in order to prevent that, they perform urine alkalinization. And before after performing the prehydration, also we have to check the alkalinity of the urine with the litmus paper. Okay, so the red should turn to blue. So if it has remains the red, the urine is acidic. So we should not proceed with the chemotherapy. Okay, only the urine is alkaline, they will start administering the methotrexate. And after methotrexate also, after the, as I said, after 42 hours, they will administer leucovorin at a 6 hours interval for up to 72 hours. So after starting, after the 42 hours, they will start administering leucovorin, which is 6th hourly for up to 72 hours. And also they will check the clearance. They will take the sample from the peripheral side. They will send to the biochemistry department. They will check the clearance, that is amount of drug present in the plasma concentration. They will check. So until the methotrexate is completely cleared out of the body, there should be adequate hydration. Hydration should keep on going till the clearance. So that is one something very important with the methotrexate. We have to ensure the methotrexate urine alkalinity. There is a checklist before administration. So we should avoid any interacting drug like we should not give cefoperazone sulbactam. We could not give cetran like that. So we should ensure the alkalinity of the urine. We should ensure adequate hydration. So till the MTX is completely excreted out of the body, completely cleared, we have to continue the hydration. So next is mesna. So as I would have already told you, so whenever a patient is taking cyclophosphamide and ifosfamide, there will be a concomitant administration of mesna. So why these ifosfamide and cyclophosphamide, they are the prodrugs. Okay. So after administration, they will force the aldophosphamide. Aldophosphamide will convert it to two metabolite. One metabolite is responsible for the cytotoxic effect. Another metabolite is responsible for the toxic effect, that is hemorrhagic cystitis. Okay, so cytotoxic effect is caused by the phosphoramide mustard, but there is another metabolite called acrolein. This acrolein will cause hemorrhagic cystitis. They causes the inflammation of urinary bladder, which will result in hematuria. So in order to prevent that, we will be giving the mesna. So mesna is nothing but mercapto. S means sulfonate, Na is sodium. Sodium to mercaptoethane sulfonate. It's a prophylactic medicine to reduce the incidence of cyclophosphamide or ifosfamide induced hemorrhagic cystitis. So what it will do, this mesna is having the sulfhydryl group. This sulfhydryl group will bind with the acrolein and will deactivate. Okay, it will inactivate the acrolein. So as a result, the hemorrhagic cystitis will be prevented. So in this case also, we will advise the patient to take up plenty of oral fluids. Okay. So whenever we are administering cyclophosphamide or ifosfamide, there is a supportive administration of mesna. Like that, whenever we are giving high dose MTX, there is a supportive administration of leucovorin. Whenever we are giving 5-fluorouracil, there is an administration of leucovorin. Whenever we are giving cisplatin, there is a post hydration along with the electrolyte replacement. And that with the drug called pemetrexate. Okay, pemetrexate is a drug most commonly they will be using in lung cancer. So all the lung cancer, the patient will be administered with pemetrexate only. So administration of the pemetrexate requires the supplementation with vitamin D12 and folic acid. Folic acid the patient will be continuously taking daily 5 mg like that. But the B12, the B12 will be taking in a scheduled manner, like 3 cycles once like that they will be taking. But oral B12 they will be continuously taking. So why these two supplementation required in order to mitigate the hematologic toxicity. So usually vitamin B12 will be given 1000 microgram injection will be given, that is 2 ml. There is a vial. Okay, it will be 500 microgram per ml. They used to prefer 2 ml for the patients. So they may feel somewhat active like that. So usually it will be given as a single shot bolus, or they will advise to infuse it with the 100 ml MS also. And also something called tumor lysis syndrome is there. Tumor lysis syndrome is nothing but as the tumor cells are getting distracted, they will release the content into the bloodstream so that the uric acid level will rise, though hypercalcemia may happen. So all those things may happen. For that also they will give some prophylaxis. Like in order to prevent the uric acid deposition, they will give allopurinol as a prophylactic medicine like. So, but these are some major important supportive cares and toxicity to be kept in mind before getting deep into the oncology. So, with that, I'm ending. Thank you. So, if any queries, if any questions you people have, you may ask me.
Thank you so much, sir, for such an enlightening session. I hope the participants would have found the spill management, high-tech route of administration, and management of extravasation to be very interesting topics. And also, thank you, sir, for covering briefly on ADRs and also supportive therapy. And I ask the participants to post your questions in the chat box.
So I hope you all find the session interesting. So we have discussed about the basic foundations about the cancer, how the neoplasm occurred, what are all the genetic errors happening, what are proto-oncogenes, what are tumor suppressor genes, and what are the key regulatory systems that are getting disrupted for the development of cancer, and about the categorization, and about the nomenclature and the basic introduction to some drugs, everything we have discussed. And for some advanced concepts, so we have to get deep into the kinetics of the drug to understand about the dose adjustments like that. So keep learning. There are a lot of things to discuss about the oncology. Practicality for dose altering, as I said, they will try. For example, if the patient is not able to tolerate, so as I told, how to calculate for each drug, they will recommend some per meter square dose or per kg dose. So from that we will calculate. So from the calculated dose we will be giving some 80 percentage of the calculating dose, or 75 percentage of the calculating dose, or if the creatinine clearance is less than 40 or 50, so we may even reduce the percentage proportions, or also we will add some other alternative drugs. So dose altering is like a trial and error. Okay, so based on the toxicity on the previous cycle, the subsequent cycle they will adjust the dose. They will just reduce the percentage and try whether the patient is able to tolerate or not. Drug interactions, as usual, all the some minor interactions will be there. So major interactions will be counteracted by the clinical pharmacist and will be put forwarded to the oncologist. And if it is found sensible, if it is found important, they may go for some other. They will not change the chemotherapy, but that supportive care drugs, they will prefer some other drugs. They will ask us, okay, they will ask us to recommend some drug with the least interaction. So we will be recommending those drugs to the patient. So if it is effective, if it is advisable to use, if it is advisable to prescribe to a patient, they will proceed with that. There should not be unusual administration of any drug, any home medicines, any traditional medicines, any over the counter. We should strictly advise the patient not to use any uh, drugs other than the prescribed drug. Before the administration of chemo, we have to check the hematologic parameters. That is, mainly WBC, platelets, RBC, that one, and the neutrophils, everything, and so on. Complete hematologic parameters, and LFT, RFT should be normal. Okay, for certain drugs, for trastuzumab, for example, doxorubicin having the potential to cause cardiotoxicity. So there will be a pediatric monitoring of the cardiac profile. Okay, depending on the drugs, but commonly if you are asking, we have to check the hematologic fitness and LFT, RFT. If the LFT is more than 3 times of the normal, we should not give the chemo. Or if it is somewhat abnormal, we have to adjust the dose accordingly. And we have to see how was the parameter, how was the result previously, what is the reason for the abnormality now. So that reason we have to correct, and then we have to proceed with the chemo. Dilution, how it is done for different age groups. So it's not depending on the age. For pediatrics, usually we used to prefer lesser volume, because the dose itself is considerably lesser than that of the adult. Or even if the patient is having fluid restriction, or for example, the drug called oxaliplatin, we have to dilute with 5% dextrose. Suppose if the patient is diabetic, we have to go for some other diluent. Like that only we will decide. Project on pharmacovigilance of chemotherapy. Yes, there is a scope of conducting a project on pharmacovigilance. There's a higher scope actually. Okay, you want me to share my PowerPoint? Okay, actually, I took a much effort for preparation of the PowerPoint. because in between my work from the morning till the evening I will be in my hospital. So in between the time which I'm getting only, I'm preparing. Okay, I will try to share it. Any alternatives to support Mesna? Alternative to Mesna, no. Maybe in future we may consider about research. Any agent that can be combined with the cyclophosphamide, ifosfamide to counteract the hemorrhagic cystitis. Instead of supportive administration, instead of separate administration, we may think of combining cyclophosphamide and mesna or ifosfamide or mesna. But if instead of mesna, we can perform bladder irrigation with the acetylcysteine. That is the only option available, I think so. When the patient blood count seems to be abnormal, see, our primary motive is not to postpone the chemo. Okay, we should always give priority to the cycle. However, the scheduled cycle, we should give the priority. We should follow that. Okay, even some 3 to 4 days delay also may cause a tremendous change on the disease progress. But some people, some illiterate people, they will say some silly reasons that they were unable to make up on that date. So like that. So this is totally unacceptable. So if the blood counts are abnormal, what we can do is we have to correct it with filgrastim, as I said, granular acid colony stimulating factor. Okay. So the next day, definitely the count will be raised. So we can proceed with the chemo. Only if there is a necessity for the GCSF to administer, they will go for GCSF. For hydration purpose, we should KGL, PK, power, tachy, and also arithmetic. We are not KCl MgO. Actually, whenever you are giving cisplatin, there will be a magnesium basic. The potassium count will fall down. Okay, the calcium count will fall down. The phosphates will be low. If you perform RFT, we can practically experience that. Okay, so in that case, it is not problematic, or else we will just inform the patient for the continuous. So even sometimes we have to be very much careful in infusion also. We should not infuse the KCl in the faster rate also. It will produce some problem on the patient. But if any exceptional cases occur, then we go for some other options. Like only normal saline they will administer. They will check the RFT parameters the next day or the very next day. If abnormality continues to be there, then they will go accordingly for the patient specific characteristics.
So, can we wrap up the session?
Yeah, thank you, the team MedoDrix and the organizing team and the team members for making me a part of this meaningful module. And I hope you all find it interesting and looking forward for the further advanced modules and all. Thank you to the team.
So, I would like to take this time to thank you for your time and commitment to provide us with the knowledge on these topics. And I also would like to thank the participants for the enthusiasm and commitment to learning.
Thank you.